This is Dr. Fazeli, and I'm recording this clip for my colleagues in nursing homes and assisted livings around mitigation and containment for COVID cases. First step of mitigation is screening, and I want to stress screening as we are getting closer to the surge, and we might actually be in the midst of a surge. We have to ramp up our testing to include testing of staff and residents who may not have the classical symptoms of COVID, and we would test them for milder symptoms or even GI symptoms, which are known to be 15% of cases. When it comes to hospital admissions to SNF and nursing home facilities, we have so far been testing selectively only those who have symptoms. But starting today, we are going to be doing surveillance screening that we would request that the hospital does before sending us patients. That would also apply to interfacility transfers. The population in nursing homes obviously is susceptible and is as susceptible as hospital population. And we know for a fact that Maine Medical Center, our largest hospital, has had about 1 or 2 weeks a protocol of demanding pre-admission screening for COVID for any transfers from other hospitals. In terms of preparing for your first case, staff cases, we would consider two things. One is quarantining at home, and if we're not quarantining, what kind of mitigation measures you will have in place. For the home quarantine, we already have medical director letters mandating staff quarantine, which is required for their application for COVID-related unemployment benefit. We also look at potential isolation of certain departments depending on where the first case develops. For resident positive cases, we are already preparing one of our units to receive those positive cases from the other parts of the building. We know our PPE capabilities, how much supplies we have, and how many we would need per case per day if we develop a case. We also have volunteers from among our staff to care for those positive cases if and when we have them. This is an action plan for an actual positive case from a kitchen staff that happened in one of the facilities that I work with. This was luckily an isolated case, and all the tests following were negative. However, I just wanted to present you with a potential plan that you would put in place for a department that has a positive case. In this slide, I want to review actual elements of a preparation plan to manage positive COVID cases within a SNF facility. This was done for the purpose of dealing with cases that might develop in the building and to be able to cohort those cases in a section where we have dedicated staff to deal with their needs. Most SNF facilities have empty beds due to cancellation of elective surgeries in the hospital. And so there is an opportunity for many facilities to duplicate a plan like this. Part of this preparation, we designated N95 masks that we were fortunate enough to receive as a donation to the facility. Those masks would be assigned to staff members who are managing this unit with the intention of covering that N95 mask with a surgical mask that would be used only for 1 day. The N95 would remain on the floor where those patients are with the staff member's name on it so that it could be used when they return to continue their shift. Within our capabilities and our supplies, we would be then changing the N95 mask as often as we possibly can. State level potential interventions. At a time when we have facilities having multiple cases in some areas of the state, we need to look at opportunities for the state to step in and to revamp the preparedness of facilities. One of the elements that is currently a struggle for facilities is obtaining viral swabs and having them on site to be able to test their staff and residents more freely without any constraint. The other uh, element is preparing an action plan for staff walkouts, which unfortunately happened in other states, and we've had the experience of that elsewhere. So we need to have the state be ready with an action plan to evacuate such facilities who can no longer care for their own residents on site, and they need to move their residents to other nursing homes. If we are to effectively carry out such evacuation and transfer to other facilities, we have to also consider the need for rapid testing at those sites. So if there's a facility that is um, needing to transfer en masse their residents, they need on-site rapid testing that hopefully can be provided by the state. The state can also have an input in mandating inter-facility surveillance screening in light of the multiple cases within facilities at this point. Also to encourage use of post-acute care and SNF beds by the hospitals to send their non-COVID cases now to make beds available for COVID cases during the surge. It would be a better utilization plan for the SNP beds than having to rely on them later for the overflow of COVID positive cases in the hospital. We need to revisit all full code residents and review on a case by case basis their survivability of a code CPR and intubation. In cases where the providers feel that the survivability is very low and any code would provide very little benefit to the residents, these codes should be considered futile, and conducting such codes would pose risk to the healthcare providers without any benefit to the resident. In cases where futile coding is insisted upon by family members or POAs, the facilities need to be prepared with an action plan that includes the involvement of the Ombudsman and the Elder Protective Services in the state to assist the facilities communicate the information to families and reach a reasonable plan that meets the residents' needs. At the state level, we also need to consider emergency legislation to extend death benefits for frontline healthcare workers. This would be in line with what is offered to police officers who lose their lives in line of duty. In terms of dealing with catastrophic events in facilities like nursing homes, assisted livings, and independent livings, the state needs a strike force that would be comprised from medical director, administrator, nurse director, infectious control nurse, that would provide teams on the ground and facilities with assistance navigating logistical challenges in a state of an emergency. We also need to consider increasing our support to the primary care doctors in northern Maine who are the main source of medical care right now. We need to lobby CMS to reestablish and reapply primary care bonuses that were eliminated with the new payment system. I hope you find this video helpful. Please feel free to send me your questions at jfazeli@maingeriatrics.com. Thank you and stay safe.